to Dr. Paul, and here we are again with the fertility crisis. And tonight we've got Dr. Kimberly Biss from the USA and Jonathan Gilthorpe from Sweden. I think he's staying in Sweden.
From
English born, but
Sweden,
staying in Sweden.
originally from the UK, but originally from Sweden.
Yeah.
And
So
and they let's bring them on.
let's bring him on and
Let's
just get
talk
jumping
about.
in. This is the last week's got a lot of feedback, but it's really disturbing. But I've had so many people reaching out saying they're looking forward to this one. But I do prepare yourself. This is heavy stuff, but it has to be said. So let's bring in Dr. Kimberly Biss. It's interesting how you have MD. You do it around differently in America, don't you? We have doctor at the start here in Australia.
Oh, yeah.
Just something minor detail. And Dr. Jonathan. Are you a doctor, Jonathan?
Well, that's the difference, Michael. So MD is medical doctor, and I'm just a PhD. So I have a doctor of philosophy. I'm a researcher, basically. But I don't have a medical degree.
Doctor of philosophy. Wow.
Yeah.
Sounds fascinating. Yeah.
And it's a fancy title, but it's an exam basically to show that you can do research, and
And boy, can you do research.
Yeah.
Well, so I work in a university in northern Sweden in a place called Umeå, and I'm an associate professor there, senior lecturer. But I just need to state that although the research I'm going to present, those things are associated with the university, the other opinions that I might state this evening are entirely my own. Because I'm fortunate, I'm one of those researchers that hasn't actually been lost their job because of speaking out against what's happened over the last 4 years.
That was one of my questions. Yeah, it's extraordinary that you have. Yeah, it's sort of killing cancel fest. Yeah. There's okay. Well, Dr. Biss, we had you on last time. It was lovely having you on last time, even though the material you talk about is heavy. But do you want to start on your slides and get us through that?
Yep. Let's go. Okay, so this is me. I'm born in the United States of America, never left, live in the state of Florida, and I've been in private practice since 1998. And if you include my residency training, I've probably cared for 8,000 pregnant women. So I don't have any, books that I've written. I'm the author of one research paper, which is actually in this slideshow. But prior to COVID, that wasn't my jam. I'm just boots on the ground taking care of patients. So that's where I gather my experience. And I have to say, as the bottom of the slide shows, that I am speaking on my own behalf. So next slide.
You got it.
So the FDA has a drug categorization, which we've always utilized as OBGYNs, but so don't other medical professionals before they prescribe medications for pregnant women. Most of our medications are going to fall under category C because ethically, at least prior to COVID, we didn't experiment on pregnant women because you not only have the pregnant patient, but the fetus. And, there's obviously a lot of ethical issues with providing a pregnant woman with a substance to see what happens when the baby's born. I would certainly categorize the messenger RNA injections that were called vaccines as a category X because we now have plenty of data showing harm. But sadly, prior to the rollout of the injections, previous experimentation with these injections on animals were not very promising. A lot of the animals died, as a matter of fact. So I would certainly categorize these as category X. You want to go
for the lay people here, like me, what does X mean?
X means do not give. Do not give in pregnancy. We do have, certain medications that would fall under that. Now, like let's say, chemotherapeutics, let's say, obviously if the woman has cancer, but you wouldn't. Some therapeutic drugs, like let's say methotrexate, they're used for other medical problems. You will want to provide that in pregnancy. So next slide. So I wanted to remind the audience there's two drugs in our obstetric history, thalidomide and diethylstilbestrol, or DES, that we all should have recalled as OBGYNs prior to offering these injections to our pregnant patients, which, full disclosure, I didn't offer these to any patients, let alone my pregnant patients. But thalidomide was first marketed in the early 1950s for morning sickness. And I think, most of us know the sad outcome of use of this agent, as if the fetuses survived, which many of them died or died shortly after birth, but they were fraught with multiple anomalies or birth defects. And they're known as the flipper babies because the most common birth defect were the limb abnormalities. And surprisingly, back in that time, we did have somebody in our FDA that actually cared about what was, allowed to come in our country. And that physician did not allow thalidomide in the States. It is still around and used for other indications. Most recently, I think, was rebranded as a drug to treat multiple myeloma, but certainly we're not providing it in pregnant women anymore. The next slide details DES, or diethylstilbestrol. This is a synthetic estrogen that was prescribed to women to prevent miscarriage and preterm labor. Many, many women received this. In the 70s or late 60s, early 70s, we realized that it was not working. So we no longer provided it to pregnant patients, and the pregnant patients didn't have any problems from the drug. However, it soon became discovered that the offspring were affected. And now we're finding actually that the offspring of the offspring are possibly affected with this exposure. And the offspring are at higher risk for genital malignancies, specifically cervical cancers. So anybody who's been born to a mother that received this drug need to get pap smears, which is what we utilize to screen the cervix for cancer for life annually, because they're at high risk no matter what their age. And I thought of diethylstilbestrol when these injections were being rolled out because, some of us that could critically think were concerned that this could possibly, transmit to the fetus. And then, would we be dealing with a multi-generational problem? And I sadly think that my, fears are becoming reality now, which I'm going to show in in some slides to come. So if you go ahead.
Just before we move on, I've interviewed 3 Australians whose mother didn't take thalidomide, but grandmothers did. And they now have, from missing limbs to, they actually have thalidomide injuries. So thalidomide is actually intergenerational as well. Is that correct?
I have not read that. I've heard that. I've not seen any data to support that. But that
these were people.
Dr. Kim, we never experienced the thalidomide tragedy firsthand when it was being prescribed. But didn't they have a higher miscarriage rate than normal in that cohort too?
Yes.
There's some similarities with what we're seeing now, the higher miscarriage rate and the higher malformation rate. Is that what you see?
Yes. Yes. Yep. So this is a very busy slide. This is the first of 2 of the timeline of how these injections were approved in the United States by our, governing bodies. The first half of the slide, well, basically this whole slide details the Pfizer trials that were ultimately published, the results in the New England Journal of Medicine in December of 2020. But this trial is what the FDA relied upon in order to grant emergency use authorization of the injections. And I just wanted to highlight, because Dr. Fauci, who I call Fraudchi, stood up on television stating that these injections were 95% effective, however, was quoting and knowingly quoting the relative risk reduction, which even our own FDA states, if you're going to discuss data from a trial, you also have to include the absolute risk reduction, because it's the absolute risk reduction that applies to the patient. The relative risk is just comparing numbers to numbers, but the clinical number that is important, doctor, if I take this injection, how much is it going to reduce my risk of getting the infection? And that was not even 1%. I have that highlighted there. And the 0.84% was actually mild symptoms. I mean, to prevent severe symptoms was 0.037%. So there was never a 95% efficacy ever. So anybody who received this injection, there was no benefit. I mean, statistically, there was no benefit, and there was obviously a lot of risk. But what I wanted to highlight is that there were no pregnant women enrolled in this trial. You were told not to get pregnant. Men were told to utilize 2 condoms and be sure that your partner is on a very good form of contraception. So obviously Pfizer did not want any pregnancies, and telling a man to wear 2 condoms tells me they knew something could possibly be transmitted in bodily fluids. But there were some pregnant women who did not intentionally get pregnant, 144, and out of them, 17 did miscarry. So that was a 12% miscarriage rate, which is not a normal miscarriage rate. In our textbooks for obstetrics and in most of the literature prior to COVID, we were always taught that a miscarriage rate that's normal in the first trimester is 15%. Now, I have never seen that clinically ever. And I think if most OBGYNs were honest with themselves, they would agree with me. Nair et al. Came out with a study in 2022 actually showing that the normal first trimester miscarriage rate is somewhere between 5 and 6%. So this already in the Pfizer data shows a doubling of the miscarriage rate, which is actually what I saw in my own clinical data. So if you go
Can I just add something to that, Kimberly, as well? So I think what people need to understand here is that the product that Pfizer tested in the trial was made in a certain way, using a certain technique to make the mRNA. They then switched, when they rolled it out to everyone else, they switched their manufacturing procedure to a totally different method for making the RNA. Well, not totally, but partially different. And that's where this DNA contamination that, you know, Russell Broadbent and others have raised, and we've raised in North Group, which is a international coalition to try and get these shots stopped until sufficient, you know, knowledge is available about them. This is where the DNA contamination problem, the SV40 promoter, came in, because so essentially the data Kimberly is showing you here is bad, but we don't know how bad it is in real life, because the shots that everyone got after that were made in a different way.
Right.
Kim, I understand that when they quote these high miscarriage rates, they're using historical data, which some of which goes back, a lot of which goes back to before we did dating scans with ultrasound, and you know,
right.
The experience in modern times where you get a positive pregnancy test, this period, have a dating scan. These are more like the figures you saw in your practice.
Correct. Correct. So if you go to the next slide, so this is the timeline. So emergency use was granted in the mid portion of December 2020. And originally ACOG, which is the American College of Obstetricians and Gynecologists, were not going to take a stance on whether or not we should be injecting our patients. They were relying on the ACIP board in our country. And so ACIP rolled these out in either 3 or 4 phases, but the first phase was the first responders, so nurses, doctors, paramedics, etc. some of which were women, obviously. So pregnant women started getting these injections in the mid portion of December. And there's a lot of data that's been conflated when it's being presented, where you have the Pfizer trial data, which is not the same as the Pfizer aftermarket data. It's two different peoples. And it's not the same as what Shimabukuro published in his article. That's the VSafe data, and that's another cohort of people. So you can't mix and match all those people. Those are three separate groups. But the aftermarket data would include those women that started getting injected in December of 2020. And the beginning portion of that was, to be published the end of February of 2021. And of course, that information had to be obtained with Freedom of Information Act. Dr. Naomi Wolf published the Pfizer paper book, which has all of, the aftermarket information. What I'm highlighting here pertains to the pregnant patients. And that information actually I obtained from Dr. James Thorpe, who received this information earlier than Naomi received her information from a whistleblower, actually. And this data has been misrepresented, actually, and myself included, until I was more informed. But if you look at the numbers, these are the reported adverse events in pregnancy in the post-marketing data. There were thousands of pregnant women that had been injected. Okay, so this only represents those who reported a problem. There may have been more miscarriages, etc., but they followed up on only 32 of these people out of the 270, and out of those, 26 miscarried. So that's where the 81% number comes from. So true, if you're looking at the numbers, it's 81% when you're calculating the miscarriage rate with that data. However, we can't sit here and say that the Pfizer aftermarket data shows us that the miscarriage rates in all patients that received these injections was 81%. We cannot say that. And if anybody's being honest, nobody saw an 81% miscarriage rate in their practices. I don't know if you want to chime in on that, Jonathan, but that's how I understand this data now.
No, I think that's correct, Kim. And it is an 81%, but it's not, what is it, 81%? So that you're correct. That it's also unfeasible. The maternity wards will be full of miscarried babies or late stage miscarriages, or this would be so well known. So this was, it's been referred to as poisoning of the well by the original publication. I guess Kimberly might go into that now, but it was one of those things put out there, and everyone that was already triggered and looking for problems is like, great, yes, this is, this proves it, but it wasn't. It was misrepresented.
Yeah, but in any event, it should have raised some concern. There's definitely
it's a signal. It's a signal.
And even though the public did not have this data, the CDC director at the time, Rochelle Walensky, did. Okay, so she was aware that something was not only with a pregnant population, but with everybody that received. There were multiple things that were happening in all populations. But she was doing a video, a recording that was published on the New England Journal. I'm sorry if you hear the thunder, but we're having a storm here in Florida. The New England Journal of Medicine, where she stated in April of that year, with no data, that these were safe and effective in pregnant women. If anything, she had negative data. She had no positive data. There were no trials done on pregnant women, but she stated that. Now, Dr. Thorpe and his wife Maggie have since found out in that same month, April of 2021, through a trust that was funneled money from HHS, or Health and Human Services here in the States. Various entities received a lot of money to market these injections, and ACOG was one of those entities. They received somewhere in the range of $11 to $13 million to market these injections to their pregnant, to us essentially. So we would provide this to our pregnant population. Now, in June of 2021 is when the infamous Shimabukuro article was published in the New England Journal of Medicine. Horribly written, very misleading, hard to find the data unless you're somebody who's skilled at reading papers and requests the supplemental data. You didn't have all the figures. What they originally published was that, oh, this is all good. The miscarriage rate is only 15%. The numbers they used were incorrect because the denominator he used was the whole pregnancy population in that particular cohort, which you can't include a third trimester patient in that number when you're figuring out something that happens in the first trimester. But in any event, published that we're good. This is commensurate with what we know in the past, a 15% miscarriage rate. There's no danger here. However, somebody read the article and one of the tables showed that you're using the wrong denominator. It should be 127 because those were the number of first trimester vaccinated patients. And then here we go again with an 82% miscarriage rate. And that's what got around, again, I'm guilty of that as well because I'm not, I'm an MD, I'm not a PhD. And sadly, we're not taught in medical school how to critically read literature. And we always think that things that are peer reviewed and published are going to be correct and accurate. We can only read the summary and we're going to have all the information. But when you get the supplemental information, it actually shows that 1,132 women received injections in the first trimester. And then when you, figure that miscarriage rate with 104 miscarriages, that actually drops the number down to 9.2. So it's kind of interesting that he would publish a higher number. But in any event, that's still higher than NAIRT's, numbers of 5 to 6%. So that's almost doubled, which again is commensurate with what, I've seen in my own practice. Now, July of that year is when both the Society for Maternal Fetal Medicine, so those are high-risk obstetricians, and ACOG jointly published a statement stating that we should vaccinate all women who are thinking of getting pregnant, or breastfeeding. And that is still their stance today, by the way, with all the information we have. Now, interestingly enough, in August of that year was when Comirnaty, which is the name brand of Pfizer's vaccine, what everybody got in the United States was not Comirnaty, was the emergency use BioNTech product. But Comirnaty is Pfizer's name brand, for this vaccine. And even in their own package insert for their FDA approved product, it states they don't have enough data to say whether or not these are safe in pregnant women. So this is the timeline for how these got approved in the United States based on no data, and what we had was negative. So here we are, and they're still approved.
Kimberly, I'm just playing devil's advocate here because I think there is a conspiracy here because information has been hidden from the public. But do you think this 82% in these two different studies, so the Pfizer post-marketing and the Shimabukuro paper, have been chosen to deliberately confuse people? Because it has led to a great deal of confusion.
So
you think there was intent?
I was, sadly one of those. I'm not smart enough to think like you just stated. I was sadly one of those that actually bought that, even though I didn't see it clinically. But now I'm more aware, and possibly because, with poisoning of the well, if you give this outlandish, figure or explanation for something, people are going to be like, there they go again, the tinfoil hat wearers,
But we saw it from the very beginning where these claims were made, by Fauci, by the WHO, by Tedros, of this 95% efficacy for the vaccines. And this is something called relative risk reduction. And for the, for people listening, that means you compare two groups and you compare in a way that makes the effect look much greater than it was. The real risk reduction for getting COVID from the jabs was, less than 1%. But they use this term. So in medical school, and I teach med students, they're taught about the difference between actual and relative risk reduction and told that you should never really look at relative because it's a way to fudge the data. But you had all these major public health authorities and organizations using the relative data to try and sell these things. So this, for me, is another example of this, bad statistics or bad, fraudulent use of statistics, I would say, to try and make something look better than it is.
Yeah, I'll give another example. So my friend and I, we both were diagnosed with breast cancer around the same time. Caught very early, we're fine. Both had the same treatment. I was placed on tamoxifen after I was treated, and I only stayed on it for 5 years because I talked with my oncologist, and he said, well, your risk of recurrence is so low, I'm not really going to drop your risk anymore if you stay on tamoxifen. And if anybody knows anybody that's been on tamoxifen, it's awful. It's a lot of side effects and whatever. So I went off of it. Well, my friend, her oncologist told her, if you stay on this drug, we'll decrease your chance of recurrence by 60% if you stay on it another 5 years. Well, because we're dropping her risk from 3% to 1%. See, that's how they do it.
Yeah.
So the drop from those numbers is huge, right? But the actual numbers is ridiculous. Why are you going to be on something you only have a 3% risk of recurrence? So that's how they kind of spin the data.
Yeah.
So this is an old slide, but probably looks the same. And it's just the OpenVAERS website takes the VAERS data, which is the Vaccine Adverse Event Reporting System data from our country, and puts it into pictorial form. And so this was the miscarriage, which everybody can clearly see in 2021 spiked very high and then went down the subsequent 2 years because many pregnant women stopped getting these injections. I would say the majority of my pregnant patients received 3 total injections. Very few had 4 or more because they were starting to, they're all in mommy groups on Facebook or whatever, and they were starting to hear that their friends were having issues either with pregnancy loss or pregnancy complications, etc. So they were done. Most patients received these injections in 2021, and that's probably why the numbers went down. However, they didn't go to 0, which I'll show in my own data. The other arrow in the previous years, because I talk about other vaccines that are provided in pregnancy and other talks, and you had a little bit of an uptick in miscarriages during that time. And that's both when H1N1 influenza was a deal, and a lot of pregnant women would receive 2 flu vaccines that pregnancy because they not only got the regular flu vaccine, but also the H1N1 flu vaccine. And by the way, if you are pregnant and your pregnancy spans 2 flu seasons, we're told as obstetricians to give them another flu injection the next time. So it's possible that a lot of these patients received 3 flu vaccines. The other thing that was happening that time is the pertussis, the Tdap vaccine program was rolled out because we're, giving our pregnant women pertussis, the vaccine for pertussis, so that they can supposedly protect their newborns when they're born. So I just kind of highlight that because there was a little uptick with miscarriages during that time. And maybe, the COVID injections aren't the only vaccines that could be causing issues with miscarriage. That's my own opinion, but I discuss that in other talks. So if you go ahead, Jonathan.
I was just going to say it's important for people to realize that this reporting that you see in the previous slide it's spontaneous reports, so they come either from the public or from medical professionals that think there may be a connection between a medical product and the side effect. So, but if you know, it's known that there's only about 1 to 2% of problems are reported into the databases. So the real effect is way higher. And even if you know, suddenly people started reporting more in 2021, 22, that spike is so big compared to the previous years. This was a signal, and it's just been written off by the drug regulators, you know, the FDA, and every country has its own organization, TGA in Australia, that's meant to review this data, but they've just written it off and said, you know, this was just people, you know, freaking out over social media because they thought they had a side effect. It's outrageous.
What would we times it by a factor? I've heard you times it by 40, but in your opinion, what would you times it by?
I looked at the deaths reported in all vaccinations in Sweden over the last 10, 15 years compared to what happened. You see a curve very much like this. So you see 40 times more deaths reported in 2021 for COVID vaccines versus all vaccines for the previous 10 years, which was about maximum of 10 per year. And it went up to over 400. So it's a 40 times increase, yeah.
Yeah, and it depends on what you're looking at. Sorry, Paul, but Jessica Rose actually looks at different things that are reported in VAERS. Like she was very highly focused on myocarditis in the beginning. And so there's different factors for different problems. Like you've heard 40, but it could be higher for other illnesses or, you know, situations. And I will fully admit I did not know, because I'm not routinely prescribing vaccines in my practice. I mean, we do offer flu. I don't do the Gardasil or any HPV things anymore. So I did, sadly, but I don't anymore. But we're not like a vaccine, like a pediatric office or a primary care office that provides a lot of vaccines. But you're legally required to report if your patient has an adverse event from a vaccine. And prior to COVID, I will be honest, I didn't know that was a thing. I didn't even know about this adverse report. I mean, and I think sadly, that's a lot of physicians prior to COVID. Now they do because they hear about it, but I didn't know that that was a thing, for one. For two, the way the system had been set up, it's so onerous to get a claim in there and time consuming that even if you knew you had to do it, most physicians wouldn't have the time, honestly.
Yeah. This is the Pilgrim, Harvard Pilgrim, also known as Lazarus study, where they came up with that figure of 1% of actual injuries gets reported to VAERS, and they had a very sophisticated setup to capture every possible adverse reaction, and they had links to the radiology, biochemistry, the electronic record, and it was almost like, you know, when you get a crash report on your computer and it fills all the details, so all the doctor has to do is go, no, I don't think so, or yeah, just send it, or yes, that's what happened and those were the results, but I think, and I think it is related, or I don't think. So when you have a proper system designed to capture all the actual adverse events, the underreporting could be 100 times. But initially, Jessica Rose and Steve Kirsch were talking about anaphylaxis, because and I, you know, my practice in anesthesiology, I saw anaphylaxis, and you know, you have no doubt. You give it, and the person starts to die in front of you, and you go, I think it was that. You know, so it's not like you can think, and that was 50x underreported, and that is so obvious because you give it and you see the life-threatening reaction. So everything else, you know, you would think is dramatically underreported, and that's where that data came from. And it also shows what we should have been doing if we really cared about capturing the true rate of death and other adverse reactions.
Can I just say, Jonathan, I live on the road, an India reporter just recording the stories on the road. I interviewed a priest. He didn't want to go public, and he said he had 300 parishioners in this small church, and 100 of them in confession had told him that they had adverse reactions, some serious. Not one single one of them had even told their doctor about it because they were scared of being called anti-vaxxers.
Yeah. I mean,
So,
this
is where it is.
I'll just fill in on this because this is something I didn't realize until I started to dig as well. So in Europe, we have the European Medicines Agency. It's like the FDA, and that's the central authority that recommends the approval of medicines. It's actually not the EMA that does the approval. They pass it up to the European Commission. And this means that because nobody can actually sue the European Commission, at least a country can't, it's a way to separate power so that EMA never gets caught actually approving something that they shouldn't. They just issue a recommendation. But as part of the monitoring system in Europe, every country has its national competent authority, it's called. In Sweden, it's someone called Läkemedelsverket, and every country has one, and they report into this centralized system. So if they get a report of an adverse event and it's serious, so it's on a list of things that would lead to hospitalization, basically, and life-threatening, they are legally required under EU law to report within, I think it's 2 weeks. So 14 days, they have to have put it into the central system. If you go back and look at EMA's annual reports on this, the compliance is actually around 60%. So national authorities are not reporting fast enough into the system. If you look at the drug companies that do drug trials, their compliance is in the high 90%. So they're doing pretty well. But the actual national authorities that should be watching this are not reporting in time. And it dropped really tremendously under COVID because, you know, they were inundated with so many reports that they just couldn't handle them. And, this tells you, again, it's a safety signal, a massive safety signal, but it's just been swept under the carpet.
It's a crowded carpet under there, I tell you.
Yeah, it's a big mat.
So this is my data from my private practice that I actually sent to Jessica Rose before, and she said, can I publish this on my Substack? And I said, yeah, that's fine, but don't use my name, because the whole reason I sent her this information is because I wanted to have ammunition with my company that has a chief medical officer that had it out for me at the time, because I was very outspoken about my concerns, et cetera. She knew I wasn't vaccinated, the whole gamut. So I just wanted to be sure that what I had collected was legit. And so the history on this is that in November of 2021, my office biller, who has no clinical experience, she's my office billing person, came to me and she said, Dr. Biss, this is weird. We've had a lot of miscarriages this month, because she was billing for the visits and she knows the codes and everything. And I said, well, how many did we have? She said, well, we had 8. And I'm in a small practice. We see anywhere from 25 to 30 new obstetric patients a month. We deliver, we used to deliver about 350 babies a year. So we're not a large practice. So to have 8 losses in a month is a high number. So I said, well, that's weird. So that's when I decided to go back and do a deep dive in my electronic record. And I kept track of newly entering first trimester obstetric patients, the miscarriages in the first trimester, and the total deliveries. And just to give everybody a little bit of insight, because you'll walk up to, somebody will have I've had conversations with other obstetricians and they'll say, no, I haven't seen this. Well, when you're in a group with other OBGYNs, unless you go into the record and look at all your partner's information, you're not going to see this because everybody's sharing the patients, right? So if my partner has a patient who had a miscarriage, never was in the obstetric practice because she lost before she even came in and entered the pregnancy, I'm not going to know that because he would have seen the patient and he would have said, oh, you had a loss. So, I mean, you really have to be active and look into your data in order to find this information. You don't see what you don't look for. So the graph to the right shows the blue bars are the numbers of deliveries that we had. So in 2020, when we were all supposed to perish, we had the most newly entering pregnant patients. And well, actually, that's what the blue bars represent. Sorry, they don't represent the deliveries, but we had the most newly entering patients that were pregnant. And we actually had the most deliveries that year to date. And the majority of them occurred in November and December of 2020. And we called them the Rona babies because, you know, everybody was locked down. You have to figure out what you're going to do. So anyway, we had a lot of births that year. We had a lot of newly pregnant patients, and you can see from year to year, the bars go down. So that's a reflection not only of pregnancy loss, but also infertility. I had many patients that we had delivered prior to 2021. They had no problems getting pregnant. I had one patient, she was actually a local news reporter, and, you know, the news company made all their employees get these injections. Her husband was also employed by them, so they were both injected with 3 Pfizers. And we had delivered 2 of her previous babies. She had no problems getting pregnant, no problems with the pregnancies. She couldn't get pregnant. She could get pregnant. She had 3 miscarriages, went to an infertility specialist, and ultimately had to have in vitro fertilization. And that was not the only patient I had that problem. Now, the orange bars represent my miscarriage rate. So in 2020, month-to-month rolling average rate was 4%. Again, I've discussed the fact that NAIRT's normal is 5 to 6%. And if I look back and I'm honest with myself, I don't even think in my years of clinical practice I've seen a 5 to 6%, you know, average month-to-month loss in a year's time. I mean, that's even high for me. And I have a I have a wide variety of patient types. I mean, I you know, all ethnicities. Some have medical problems, some don't. So I'm not, you know, a specific patient population. But my miscarriage rate was normal in 2020, 4%. So then in 2021, it jumped, and we did have the highest number of losses, like I said, in that month of November. But the average was 8% month to month. So my rate went up by 100%. And then it doubled again in 2022. Now, that data only went up to November of 2022. In December, I will tell you, my rate was 27%. And then in January and February of 2023, my rates were 30%. And they didn't decline back down to normal until the summer of 2023. And that's concerning to me because, again, I addressed earlier, most of my patients received the injections in 2021. 65%, I also track that, 65% of my entire obstetric population elected to get these injections. The majority, I would say 80% were Pfizer. The rest were Moderna. I had a handful of J&J. So majority were Pfizer. But the majority were done in 2021. So we were still seeing an effect going on from year to year. So that's, I don't know if you want to chime in on that, Jonathan. She's got an excellent Substack, by the way, if anybody wants to look her up, but she's just a whiz with data.
Yeah.
Can I just ask a question? When you said it went back to normal, did it go back to 4% or 8%?
Went back to 4%.
4%.
Mm-hmm.
And
Yeah.
what proportion of pregnant women are now taking regular vaccines? Kim, did that go down to 0 from 60%?
I wouldn't say zero, but pretty close. I mean, most people, I don't see pregnant women anymore. I stopped delivering in December of 2023, but I still have a very robust gynecology practice. And, I'm right next door to my ultrasonographer. So if there was going to be an issue with anything now, I would know about it because she would be telling me, oh my gosh, I can't believe I'm seeing blah, blah, blah. But I would say with all vaccines, patients now are pretty hesitant to get anything because, the curtains were opened with a lot of what we recommend, not only vaccines, but medicine in general. I mean, that JAMA study that came out showing, trust in physicians is at an all-time low. So a lot of things are getting questioned, but I will tell you, right before I stopped delivering was when they approved the RSV, respiratory syncytial virus vaccine for pregnant women. And I stormed into my partner's office and I said, we are not going to be providing this in our practice or offering this in our practice because the placebo groups or the injected arm of the trial had a lot of fetal deaths because it was causing prematurity. Well, the answer to that from ACOG is, well, don't offer this until the woman's already 32 weeks. So it's okay to put a 32-weeker in labor. I don't understand that, but in any event, we don't offer that. We don't recommend that. So anyway.
Were you also seeing malformation, babies born malformed, or is it just miscarriages?
So I fortunately did not see a lot of that in my practice. And the other issue is stillbirths. I did have, at the time COVID started, I was the chief of staff of my hospital, and that lasted until December of 2023, 4 years. I had the obstetric unit manager run the stillbirth numbers for me from 2020 to 2022. And I will say the level at my unit was the same. There was no change in the number of stillbirths. Overall, we have a higher number at my institution because we're a high-risk referral center. So we have a lot of sick patients. The stillbirth rates are going to be increased in them. But our levels did not increase from year to year. Dr. Thorpe does have data from other parts of our country, Canada. I believe Scotland's rates went through the roof in some parts. Michelle Gershwin, who now has a different last name, I'm sorry to say, I can't. She's our nurse whistleblower from California who came out, and I believe she's in the Fresno area. I'm not 100%, but her stillbirth rate data was pretty shocking. But mine did not increase, and I didn't see in my own practice a higher number of malformations, but I know that those were increased.
What has seemed to peak recently is and I just saw this yesterday or the day before on X, so I haven't checked the data, but Claire Craig had posted, and someone else had posted, but she reposted that the rate of neonatal all-cause mortality in the 1 to 4 age group is, gone up dramatically since 2021.
I have that slide actually. I made screen. That's by the Ethical Skeptic.
Yes,
by Ethical Skeptic, but it's CDC data.
Yeah. So this is what you would expect, though. Maybe if this affected, then transferred onto the children that were born in that period, so maybe the miscarriage rates drop down again because people aren't taking the shots. But then the children that were born from those vaccinated mothers are affected, or some of them.
Right.
Yeah, wasn't there a study from Israel really recently? I think Litwitzer, Bleuy, and Kutzler, and one of the things that I noted was that they said that nearly half of there was also similar to what you saw, a doubling of miscarriages, as I recall, but half of them were later, in the second 20 weeks. So that implies that stillbirths is an issue, and I'm sure Jonathan's going to talk to us about the check data as well.
Yeah. I mean, the problem is getting the data right. So Kimberly had it because it was her practice and she was working with these patients. But to be able to request this from anywhere is more or less impossible. I haven't tried in Sweden because I know I would need ethical approval. So I need to get a doctor to write that because I'm not a medical doctor. And when it's approved, what the committee will say, well, this is at risk of affecting willingness to vaccinate. And therefore, they're not going to provide it. And if I did try to get it, it would cost a lot of money. So simply people aren't getting access to this data to analyze it. And the authorities that have the data aren't analyzing it, or they're not publishing the results. They're just sitting on it. So that's basically the crux of the problem is getting access to the data.
I think it's very sad because I'm part of a very large OBGYN medical group. We span several states, but we're predominantly in Florida. My colleague is part of another huge group in Florida. We could have had so much data if the powers that be in our company said, hey, we're going to recommend this injection. It's new. Let's be sure, we're not seeing any problems. But nope, sad.
Yeah, really.
Do you want to move to the next slide, Doctor?
Yeah, sure. So this is another busy slide, but I just wanted to go into how we are as women with ovaries not the same as testes in males, and sperm. Sperm is reproduced every 24 hours, whereas we don't reproduce our eggs. So, all of our eggs are going to be developed. They're in the form of, primordial, follicles or the beginning of eggs. And that's by 22 weeks, which a whole gestation is 40 weeks. So a little over halfway through the pregnancy, the female fetus has all the eggs that she's ever going to have, and they slowly start to decline even by birth. She doesn't have as many as she started with. And then by puberty, she has even less, about 300,000 out of many millions that she started with. And then what menopause is actually when the eggs are totally gone. And the average age for that is about 51, 52. However, sadly, there are some women now going through that very much sooner than even age 40. I was talking to a reproductive endocrinologist a couple weeks ago whose own daughter was mandated to get these injections to go to college. And she's 19 and she is in menopause. And because that would not be very ethical, but I'm sure one of his associates is giving her fertility injections in order to generate some eggs that they can, retrieve and freeze for her to have later on in life. But she's 19.
I've met people over here, Doctor, who are in their late 50s and have started menstruating again.
Mm-hmm. Oh yeah, you saw that.
Years and years after menopause. Yeah.
Yep. A lot of postmenopausal bleeding we saw with no explanation. A lot of women had to get hysterectomies for that. Scary. So anyway, this is just showing that we got all we got when we're born, so we really shouldn't be screwing around with it.
I ask just for a sec. When you're saying by puberty they're down to 300,000, what's the body doing? Getting rid of? Is the body sort of filtering them and deciding which ones are healthy and which ones are not, or seems to be a big waste?
Yeah, that's a good question. As a matter of fact, if you're on birth control pills, you're supposed to, how they work is you're suppressing ovulation. You're suppressing the eggs from being made or ovulated to become a pregnancy. But even if somebody's on a pill, she's still having her follicles, her primordial, the beginnings of the eggs are going away. So I'm not really sure why that
No,
happens.
it's a good question, Michael, and I don't know the answer to that either. I'm going to go and look it up afterwards.
I'll just take the accolade. They're asking a question.
Yeah, please. Good question.
All right.
So, next slide.
Yeah. So this is the most recent publication of everything that I'm going to show, but this is the study that was done on rats. This will be a good time to plug my research group. If anybody's interested, if you Google abrg.org, Advanced Biologic Research Group, we are trying to get a study launched in humans that was basically done here, with the exception we're not going to be doing ovary biopsies, but we are going to be checking AMH levels, which is anti-Müllerian hormone levels, which is a fertility marker. But what these researchers did was studied this in rats. They injected the rats and they checked all kinds of levels, AMH, FSH, estrogen, but also did biopsies on the ovaries and found that there was a 60% reduction in the primordial follicles of these rat ovaries. Okay.
And that was giving them the same equivalent dose that it would be given to a human. So much less for a rat, because they only weigh, 300 grams or something.
Correct. So this was published this year. Very concerning, and, makes sense to why we're seeing problems with fertility around the globe, but also seeing people that are having menstrual issues or, going into premature ovarian failure, which is what would be an early menopause. So very concerning, but we want to replicate this in humans. But the problem is, it goes against the narrative, and it's very hard to get funding. We've been self-funding a lot of what we've done thus far. We're perhaps going to get it in the hands of some higher ups at the NIH, but to be continued. So anyway, next slide.
And this is a study that should have been done as part of the approval process for the products. This must have been requested but it wasn't. Right.
So these are earlier studies that were done 2022 out of Israel, showing that this does affect sperm, not only the total number of sperm, but also the motility of the sperm, which both are important with pregnancy. Both went down. Now, these patients were only studied up to 125 days, so that doesn't mean that the numbers were only changed by that amount of time. That's just how long they studied the subjects. So the sperm is affected. Next slide.
So there's been no updates on those studies? It's just 125 days. No one's followed up.
I haven't seen any. I don't know.
I haven't seen. No, this came out quite early in 2022 or end of 22, but relatively early in the COVID drama. But I haven't seen any follow-ups.
This is from the late Dr. Arne Burkhardt, may he rest in peace, pathologist who studied a lot of postmortem, after the vaccine people. This was a male who he looked at, and this was testicular tissue. And what he was staining for was spike protein. And the brown, all the brown you see in the slide is staining spike, and there's very few sperm. So pretty much his point was almost the entire testes was now full of this spike protein and no sperm. if you go to the next slide, these are two studies that were done on breast milk. They were both done by the same author, leading author, but the second study was basically just to reproduce and confirm what the first study showed, which the person did, basically showing that fully intact vaccine RNA is found in the breast milk of moms that are feeding their babies that were vaccinated. So clearly, like Dr. Fauci said, it stays in the arm. But the other thing that's concerning is that I think my next slide might show this, but there were people that reported issues with their babies that fed the breast milk. And that also shows that this may survive the gut. So the fact that they are wanting to put these products in our livestock and in our food, people say, well, don't worry about it because your GI tract is going to get rid of whatever. But that's not necessarily the case, perhaps, because these babies fed and then they had issues. I bring this slide up. This is from our VAERS data, because the first item listed, death, I don't know about anybody else on this call, but I've never heard of a woman breastfeeding her child and then the baby died because she breastfed. I mean, this is a freaking problem. You know, again, this is VAERS data. This is supposed to alert the CDC and the higher ups that we have a problem. And yet we're still taught or told to tell our patients by ACOG and other entities that if you're breastfeeding, it's no problem. You can get these injections. So
Yes, and you had the breast milk going, what, bluey green color in some women? I mean,
yeah,
that's
Yeah.
that's very weird. I mean, it's not just it's not just happenstance, I don't think.
yeah. So next slide. This was published last year showing fully intact vaccinated RNA was in the umbilical cords and placentas of the fetuses that were studied in this study, which these authors were actually very happy about, ironically, but just goes to show then if it's in the umbilical cords and the placenta, it's going to the fetuses. And when we give a mother an injection, a vaccine, we're not giving her a vaccine so that the products we're injecting in her arm go all the way over to the baby. I mean, for God's sakes, how do we regulate that dose? I mean, Kevin McKernan actually wrote a very interesting Substack on breast milk, and he just took some numbers and figured out that the human dose of these injections, if every part of that dose went to the fetus, because the weight of the fetus, everything in pediatrics is based on weight when you're giving them medications, would be, I don't know how many times the normal dose you're giving to a human of these messenger RNAs. I mean, it's just crazy. But anyway, this is one study in humans. The next study slide, I believe, is the one I have on the rat trial that came out in this year. Now, what they did was they gave the Pfizer product to rats, and then they that were pregnant, and then they tested the fetal circulation, showing in the fetuses of these pregnant rats, there was not only vaccinated RNA, but also they were actively producing spike, and thus the antibody, the immunologic reaction in the fetuses was happening while they were still in the mother's womb. Now, I bring up IgM in the middle of the slide. There's two different types of antibodies we're looking at when we give somebody an injection. The first one that's formed within the first month is IgM, and then you convert over to IgG. when we vaccinate a pregnant mother, and this is why we don't give her a vaccine the day before she delivers. We want to give it at least a month prior to delivery because we want her to be producing IgG. IgG is what is passed through the placenta into the fetus. IgM is too big. It will not passively pass through into a baby. So if there's IgM that's found in these rat fetuses, they're producing that on their own, which proves that whatever's given to the mama is going full into the fetus. Her cells are getting, filled with these RNAs, and they're turned into spike-producing factories, just like what happens in all of us that got these shots. So concerning. Next slide. So this is what Jonathan brought up earlier. This is from the Ethical Skeptic, and that's what he or she goes by. That link below is to the article that he or she wrote, but this is the pictorial view showing that after the vaccines were rolled out, these are all children from pregnant vaccinated moms, and the all-cause mortality up to age 4 is increased. So this is CDC data, by the way.
Yeah.
So concerning.
Clear.
It's at 25 sigma. That's an extraordinarily high number.
Mm-hmm. Yeah. Sad. So this is the only paper I've ever been an author of. James is our leading author. Dr. McCullough is also one of the authors. Albert and Julie they are experts with the VAERS data. I mean, they can take all that data and tweak it, and they're just amazing. I'm always texting Julie trying to get some numbers on, hey, how many thyroid conditions have you seen in VAERS? And I get a text in 5 minutes with the numbers. But anyway, what we did was at the time this was published, it was 412 months worth of information. We compared COVID vaccines to flu vaccines because flu vaccines have been given for many, many, many decades to pregnant women and are considered the gold standard and safe vaccine for pregnant women. So we looked at women that received flu vaccines going back 412 months. We had 40 months at the time of COVID vaccines being provided. And then we had 412 months of all vaccines, excluding COVID vaccines, because women get Tdap and some other vaccines if they're going to travel out of the country when they're pregnant. And we looked at 35 adverse events that have been reported to VAERS. And if you go to the next slide, there's a table that shows what that looks like with the numbers. So if you go into the upper left where it says miscarriage, so the 3494 number is the number of miscarriages reported to VAERS in women who received the COVID vaccine. The middle number is the flu going back, 412 months, and 93 is all vaccines combined. Now, if you go to the next slide, it shows what the statistics utilize. We use proportional, the PRR, proportional reporting ratio. So what that 114 number means is you are 114 times more likely to miscarry a pregnancy if you receive the COVID injection versus taking a flu vaccine. And we did the statistics for all 35 events. So stillbirth was another that we looked at, and that would be a 72, higher risk of having a stillbirth should you receive a COVID injection as opposed to receiving a flu injection. So
And isn't a PIR2 already a signal?
Yes. Oh, thank you, Paul, for bringing that up. So per the CDC guidelines, if you have a signal that's higher than 2, you're supposed to take a look at that and see what's going on. So everything that we looked at, all 35 events, had a much higher signal than 2. I mean, when Jim tried, Dr. Thorpe had written a paper a couple years ago, and he had a graph of all the, greater than 2 for all the things. I think at the time he had 13 adverse events. He couldn't even put miscarriage on the graph because that was way over here with as far as how far off it was. So very startling. I think that's probably the end of my sad slideshow. Oh, these are my thoughts as far as why we're seeing, the elevated miscarriage rates. Now, first and foremost, before these injections were even rolled out, Doctors Eden and Bhakti had some concerns because the spike protein is very similar to proteins that are in the syncytioblast layer of the embryo, which is a layer around the embryo as it's traveling through the fallopian tube, because in the fallopian tube is where fertilization occurs. And then the embryo travels down the tube and then implants into the uterine wall. Well, that layer, the syncytiotrophoblast, has proteins that are very similar to the spike protein. So if you're developing antibodies to the spike protein, perhaps those are now, attaching to this embryo and causing this to not allow to, implant or whatnot. So that's one possible theory. Other theories are listed beneath that. I mean, inflammation is caused not only by spike protein, but also by the lipid nanoparticles, which are the fatty envelope around the messenger RNA that's injected in everybody. They both cause inflammation. Inflammation does nothing good with anything pregnancy, especially when you're trying to conceive. I mean, most women that have endometriosis, that's the culprit behind their lack of, ability to conceive. It's not really having the scar tissue or the implants themselves in the pelvis, but the inflammation it causes. The endocrine issue, I mean, the lipid nanoparticles are fat lipids. All endocrine glands like fat. I mean, cholesterol is the fat where all our hormones are derived from. And so all of our endocrine glands are sucking in these lipid nanoparticles. Pfizer had that data way early on in rats, showing that the ovaries highly concentrated the lipid nanoparticles. So, that could be a possibility. Microclotting, I mean, we all know by now these cause clots, and especially in very small vessels. So there are small vessels that supply the endometrial layer, which is the lining in the womb that's been developed to nourish a pregnancy. And then now, thanks to Kevin McKernan and others, we know that there's DNA in these injections that some people received. So possibly getting into the embryo or the eggs or the sperm, before fertilization occurs. And then the last thing I can't see because I cut off the slide, but Jessica Rose showed that there's actually some competition for the estrogen receptors with regards to the spike. So, there's all possible ways, but again, this takes data, this takes research, this takes funding. I mean, our research projects in my group are not very big projects, but you'd be amazed at how, easily you could spend $100,000. I mean, it's just, crazy. I mean, just to get IRB approval, it's $3,000 for most IRBs to look at your project to see if it's legit. And they take your money, and even if they say it's not, you don't get your money back.
No, and you need people to do the research, and that's more or less $100,000 per year per salary.
Yeah.
When you take in the pension costs and other costs as well. So it's big money. And the research cycle or the grant cycle, it takes 1 to 2 years to write the grant, get it approved. If you get it, maybe with a 20% success rate. So if I decided to go and study this now, probably I might get funded in 1 to 2 years, and then you've got to recruit people. Yeah, so it's very slow, unless groups are actually working on this at the moment, and the ones that are, really are not looking, because there's this huge barrier to dragging back the carpet and looking what's lying underneath.
Yeah, we're trying to self-fund, and I know you have now coined, blokes for babies. We're trying to coin moms against mRNA, because we do have a lot of mom groups over here that work very hard to not mandate these injections in children. Especially, we have a whole other group that worked against successfully in a lot of universities and colleges here to get rid of the mandates for them. So we're trying to rile up the moms and the grandmoms, because do you want grandchildren? Fertility is an issue.
I have to say, I don't know what it's like in Sweden and America, but over here, vaccines are now a religion. They're not a medicine or whatever, the vaccine there. You go to doctors' surgeries and the walls are like altars to vaccines. All these pretty, beautiful, happy, smiling kids next to a syringe. And we have a thing over here called no jab, no play. So the kids can't go to daycare or kindergarten, anything, unless they're all fully vaccinated. So there's a big thing happening over here of homeschooling, which is taking off like crazy, because the parents just literally can't trust the medical system, and even can't trust the school system, because here in Victoria, where I live, at 5 years old now, the kids are being taught they can be any gender they want and stuff like this. So it's almost like philosophically, it's almost like we've lived in this reality, and now someone's trying to push another reality over us. And in this reality, Jonathan can decide he wants to give birth tomorrow, and no problem. And vaccines are safe and effective no matter how many people we bury.
Yeah, but calling these shots a vaccine is a stretch. It's a very different technology. Kim, you were just talking about the fetus being transfected and producing producing mRNA and developing spike protein. So, I mean, that's not. This is not. We have to stop calling it a vaccine. I call it synthetic gene injections. I notice we've used the word product, but I think that's one of the tricks the devil here has been playing by changing the word vaccine, where this product is something very different.
Well, you know why they did that, Paul? Because, okay, I'm going to give you, ma'am, this shot that, has never been approved prior, because all the previous studies in animals, they died. Do you want it? Nobody would have taken it, but all of us have taken vaccines our whole lives. So you call something a vaccine, the lay public, and even sadly, not the lay public, my colleagues, oh, it's safe. I always get a flu vaccine. What's the difference? It was all of this was up here, fear, manipulating words, even the approval of Comirnaty, made everybody think that all of these vaccines at that time were FDA approved. It was all word salad, it was all a psychological. I mean, for God's sakes, pregnant women I've taken care of for many years, you can't even get them to take a baby aspirin we recommend to prevent preeclampsia. If they've had preeclampsia in a prior pregnancy, they won't dye their hair. They won't eat tuna fish. But 65% of my patients, and I know in California, the vaccination rate of pregnant women was in the high 90s, stood in line. Nobody held them down. stood in line, got the shots because they were made to be so afraid that they were going to kill their baby if they didn't get these injections.
The big one over here now is the whooping cough.
Mm-hmm.
They're pushing that, and I interview lots of grandparents who can't see their grandkids because the grandparents refuse to take the whooping cough vaccine, and so the kids won't let them see the grandkids up to a year. I get that an awful lot.
I mean, but what I'm seeing consistently now with the new vaccines is that, or other vaccines as well, is that what seems to happen is that the population that have been vaccinated are now more vulnerable to serious disease. So you see it with the tick-borne encephalitis. It's a nasty virus that's carried by ticks. Birds, deer have it. Sorry, Michael?
Is that Lyme disease or something?
No, that's Borrelia. So that's a bacteria, but it's carried by ticks. It's a flavivirus, but it's it's carried by the same ticks. But this can give you a really bad encephalitis, hospitalization and really sick. There's an island off the coast of Sweden called Åland where I think about 80% of people taking it, they have a lot of seabirds, they have a lot of ticks, they have a lot of TBV, compared to areas of Sweden where you have a lot of ticks as well, and a lot of TBV, but less vaccination. So they have much more serious cases of hospitalization and days in hospital in intensive care in Åland compared to Sweden. So on the population level, it's looking, and I've seen this with other vaccines as well. I think you're probably going to see it. Well, Kimberly mentioned it with the RSV vaccine. That actually, I think in that study they pulled it, didn't they? The Moderna mRNA vaccine for RSV, because what they saw in the neonates or the babies that had been injected, they actually were getting RSV or serious RSV at a much higher rate. So it wasn't protecting anyone. It was actually pushing, making people have more serious disease. But of course, the drug companies will throw tons of money at this to hide the data so that they can sell it. Because as soon as it's on a childhood vaccination program, it's $1 billion a year for them in the US.
Right.
Not only that, but it seems to me that the only thing standing in front of Big Pharma reaching even greater profits is the natural immunity of human beings. So you remove that, and suddenly you got.
But it's the fear thing, right, Michael? So if people can get something for free, if they think it's going to stop them getting really sick, they will take it. And I've spoken to my hairdresser, for example. Her and her 2 kids all got this TB vaccine because they were afraid of getting TBV. They'd heard it in the news. So that fear factor is so powerful in motivating people, and that's why it's used for marketing. Unfortunately, we don't have honest and scientifically competent people in these positions of power in these regulatory authorities anymore. They've been switched out through revolving doors, or they're getting backhanders from pharma, or it's just been taken over from the inside. So people believe they're getting honest information from regulators, but they're not.
The only difference I saw, though, I don't know if you saw it, was monkeypox. There's monkeypox in Australia. We kind of laughed it into the silence. I don't know if that was the same in Sweden and America.
Pretty much, yeah. Well, they even changed the name of it to Mpox to try and tone down the social response to that.
It hurt somebody's feelings.
What was that, sorry?
It hurt somebody's feelings.
Yeah.
A monkey. Can I just post something quickly? Just no offense, Doc, but that was a really, really heavy slideshow. So we did this to get past when they brought out monkeypox. I'll see if it'll play. Let's just have a bit of a laugh before we get into Jonathan's. Where is it? And this is how people in Australia were fighting back. We did one, but loads of people were doing it. Can you see that?
Monkeypox.
Yeah.
It's not going to be a pandemic. Should we be scared? Did you eat my banana?
Yeah, that was so simple. That went uber viral, and other people started replying. So suddenly we had all these people putting on monkey face. But it sounds silly, but what it did was monkeypox vanished. It was a way
Yeah.
of attacking the fear
Yeah.
with humor. You know what I mean? Because to the fear, our country has been crippled by fear.
Yeah.
It's stuck around. In COVID, it was. I used to tell people it's like the country's been invaded. Instead of the soldiers invading forces goose stepping down the street, they're invisible, but they're around people's souls. And people are just defaulting to silence and compliance. And that was across the Australia, which previous to COVID saw itself as we're all a bit like Crocodile Dundee. We're not scared of anything. But that turned out to be a lot of crap. And they were terrified of whatever the government told them to be terrified of. Yeah.
I'm very pleased you're allowed to homeschool, though, Michael, because in Sweden it's actually illegal. You're not allowed. You have to put your child into
No
school.
way.
Yeah.
Wow.
Yeah.
I wouldn't be surprised if they do that here, but no way. That's amazing.
Yeah, I know. Yeah.
Wow.
Mm.
Wow. I mean, you can always tell homeschool kids over here because they're bright. They seem to be looking around at the world as though the world's their teacher, and they're just absorbing information. They come up to you like a little person and go, "Hi, Jonathan, I'm Michael." And you're like, "Whoa, what's this kid?" You know, they're just so lovely, you know?
Well,
Yeah.
nobody wants to sit in a classroom for, 6, 7, 8 hours a day. I mean, who does really?
And then you come home and you have 4 hours of homework.
Yeah.
Like, what are you doing at school?
Yeah. And then you forget it the next week because you don't need to remember it because it's just,
Right.
learning information and continual assessment.
Yeah. That sort of thing. Do you want to go to your slideshow now?
Yeah,
Jonathan?
I will do, Michael. I don't have so much, and in the interests of time, I realize people but I just wanted to go through some things that happened in Sweden, which kind of show the way that this has progressed and never been dealt with. So basically, I got involved in this side of things in late 2022, and that's because I joined this organization called the Doctors' Appeal. It was the Swedish response to the Great Barrington Declaration, and we organized a conference in Stockholm in January 23, and that's actually, I think, the slide that Kim showed from Dr. Arne Burkhardt, who died sadly later that year. He was this German pathologist that came out of retirement to start looking at all these autopsy samples of people that had died from the jabs. So he was actually on the conference, and that's where his story of this, effect of the testes came out. But anyway, what we'd started to see late 2022 was this drop in the number of births in Sweden. And I wrote this together with Dr. Sven Roman, who's the chairman of the Doctors' Appeal, and we put it out in the Daily Skeptic because there was no way we would be able to publish this in a peer-reviewed journal. And if we did, it could get it out, it would have taken years. And we thought this was so important to get out that we published it in the Daily Skeptic, and it was a pretty inflammatory article. We used language that you wouldn't use in a normal scientific article. We bigged it up because we wanted people to react to that. So yeah, what did we see? This big drop in birth rates associated with the vaccination rollout. So if you could just go to the next slide, what it looks like.
Just look at the visuals there, though, of that ad. They're all wearing blue gloves, blue tops, blue masks, and
pregnant woman,
hand over it. She's loving it. So she's loving it. That's why she's taking the vaccine.
Yeah.
The psychology, even in the middle, you got a guy in a white there with his, it's just.
Yeah, I see. I agree. This picture was not chosen by us. It was chosen by the Daily Skeptic.
Oh,
so
yeah, I
right.
understand. But it shows the propaganda that we've been up against.
Yeah. I mean, this is this outlet that's publishing, fringe articles, but, I'm not under any illusions about maybe what the real, role of Daily Skeptic is in kind of gatekeeping. But anyway, so what we saw, this is a graph showing historical birth rates in Sweden back to 1900. And the blue line is a kind of the real rate, and the red line is a trend. So if you take the previous 10 years and roll it into an average, you kind of smooth the curve out a little bit so you can see what the trend would be. And so the little red dot right on the right is what happened in 2021, where suddenly, you know, if you look at it in this context, it doesn't look like a huge drop, but you can see how it's quite steep. You know, it's a big drop, and it's around about 6%. The yellow dots are periods in history where the birth rate has changed by 6% up or down over that period. So 1920, you saw quite a big drop coming after a baby boom. There was another baby boom in the war years, 1945-ish. And then, you know, other times after that, you've also seen baby booms and also drops. So you could expect a drop, but how big was this and when did it actually happen if you look at the month level? So if you go to the next slide, what we saw was that, so starting on the left is monthly, October 21, only about minus 0.9% compared to the, so this is looking at women aged 18 to 45, so where the majority of births come from per 100,000. And comparing it, I think, to the previous 2 years, it's the trend. So what happened over the previous decade, we've compared each year or each month to that on a monthly basis. And so what you see is the difference really kicked in there between December and January 2022. So something happened where the number of babies being born suddenly dropped by 6%, and then it increased up to a maximum of 12% by October 22. And this is precisely 8 to 9 months after the jabs were rolled out to the fertile population in Sweden. You know, similar to what Kimberly said, first it went to frontline workers and to people working in care homes, etc. And then it went to the elderly, and then they would decrease the age group. So by the time they got round to the 18 to 45-year-olds, it was a ways into 2021. But exactly 8-9 months after, you see this decrease. So how does it look now? If you go to the next slide, please. Well, we concluded in this article, and this was, you know, this is what we said. It is unknown if or how many mRNA vaccine, how mRNA vaccination is connected to the decline in birth rates seen since 2021, not just in Sweden, but throughout the world. So this pattern is seen elsewhere. It's equally unknown what the long-term safety effects of mRNA vaccines are. They're only now being tested on a population. Correlation doesn't prove causation. However, never in modern history has such a synchronized decline in birth rate been seen across the developed world, precisely aligned with a massive rollout of a new and experimental medical treatment. So I don't think anything in there is untrue. It was a fair conclusion, and it was just really a call for the authorities or whoever had the data is, please look at this, because this is a problem. So if we could go to the next slide.
That, I'm just saying that really is the problem. I said on the last show, I talked to a man whose wife is a midwife at a major Sydney hospital, and they were having emergency discussions about the amount of stillbirths and miscarriages. And he said that none of them were allowed to mention the jab. They come up with climate change, this, whatever, but none of them were allowed to even mention the vaccine. So what you're saying here is there's the evidence, and we're not saying it's there, but they won't even look.
No.
It's like you're doing a plane crash investigation and the engine fell off, and they just go, well, it couldn't be that.
Yeah. I know they've been. This has been brought up in Parliament in Sweden. It's been on national TV. They interview, you know, people in kindergarten. They talk to everyone. Oh, it must be terrible. The war in Ukraine is affecting the rates. But they never mention the vaccines. Never mention the vaccines.
Yeah.
The thing is, if you look at the rate of, and they say, you know, well, people are deciding not to have children because the world situation is terrible. Well, if that's true, then the rate of abortions should change, either go up because people are saying, oh, I'm pregnant, I don't want to carry this child into the world, or it would go down because people are not choosing not to have sex at the same rate. But the rate of abortion has not changed over the last 4 years, but the number of births has gone down dramatically.
Mm-hmm.
So, yeah, this is what it is in numbers, and this is just counting 22 and 23, so not 24. So this is a graph that Sven prepared, but it's basically about 30,000 So 10,000 less births expected in 22 and 15,000 in 2023. This is catastrophic for Sweden. The population is only 10 million, so it's not a big country.
And you've got huge migration, I believe, for bringing in lots of people.
Yeah, well, there has been, but I mean, it's not as big as maybe it's blown up on the news. There is migration, but those
I was wondering if they're
people are more
covering
likely to have babies, I would say, because they're they generally have bigger families. So it's not having a net effect on the number of births. They're dropping. Then you can go on.
Jeez.
So this is what it looks like now. This is out to July 2024. So this, the start of the graph is the same. The light red colors you saw, that's 22, and then middle red is 23, and the dark red to the right is 24. So it's gone down. It's increased, although there is a kind of episodic wave to it. But we're still down at the minus 15% level on some months. This is it's not gone back, as Kimberly talked about the stillbirths or the number of miscarriages going back to normal. The actual rate of births isn't going back. And as I said, no change in the rate of abortion.
What would the graph of excess mortality, how would that rate to this?
It's gone up a bit in Sweden, say 3 to 4%, but not as much as other countries. For example, Germany, other European countries have had quite high excess mortality, going up, I think, around to 15%. But, this is multifactorial because Sweden didn't lock down, and we didn't have the same fear. We did have restrictions, but we didn't have the same kind of fear conditioning that was happening in a lot of other countries, especially Commonwealth countries, UK, Australia, Canada, New Zealand. I mean, I really feel for you guys because you had...
I was from Melbourne, so I was in all of them. It was 2 years of lockdowns almost. It's insane.
Yeah. So I think that's had an effect on all-cause mortality, also because the health system was open. People could go to hospital and get treated or be diagnosed. That will have kept things down, but you do see an increase. You see an increase in certain cancers, particularly among younger age groups, and so this is just showing it in a different way. So the change in birth rate 22, 23, 24, it's an average of all those months into years. So you see we're down at 14% lower than they expected, based on the trend. So you can choose the trend with different years. It will have a slight effect on this, but bottom line is it's down. We can go. Yeah. So, I moving on from Daily Skeptic, it then took 2 more years to be able to get together with a team that wanted to look into this, and we managed to get hold of this data from the Czech Republic through Thomas Furst, who's one of the authors here. He was able to get this data from the Czech Republic by FOE, by Freedom of Information request, and it was really difficult. But though repeated requests, they got data on the number of women that were vaccinated either before their conception or during pregnancy, and then the number of births that resulted in. So this was data from 1.2 million Czech women. Really the first national study that's been done. And what we found was, if you go to the next slide, essentially, it's a bit of a busy graph, but what you see on the top is a bar chart that shows how many people, women in this group, had been vaccinated. So it starts very low and it goes up into late 2021. You see that it goes to a peak and then it levels out. And below what you see are 2 overlapping graphs. And the reason they're so wide, they look like a river. They're the kind of confidence intervals. So how certain can you be that this person had a successful conception? So pregnancy that led to a birth. But if you look over on the right, what you see is as more and more people got vaccinated or didn't, then the confidence levels kind of get tighter, so the graph gets smaller. So what you see by the end in 2023 is the upper line of the number of births that are in the unvaccinated group, and the lower line is in the vaccinated, and the middle one is the average of both. So you see 30% more births in the unvaccinated than the vaccinated. And if you trace it back towards the left to the, where the river gets wider, well, you see that already started very early in 21. You see the same pattern. It just became more certain as you go along in time. So this, if you go to the next slide, it just, I think, summarizes that. So why this is important. So it's the first national study to analyze birth data in relation to COVID vaccines. The data set is very limited. I mean, we can't look at potential confounders. So there are things that would, happen in unvaccinated women that might lead to this effect that wasn't vaccination. Maybe it's their ethnicity, their willingness to vaccinate, their migration rate, whatever, we can't look at those things because all we got were these numbers. But it does show a signal which has to be followed up. I mean, you can't see a difference like this of 30% and just say, no, this is just, bad science. You haven't analyzed all these other things that might have led up to it. You need to go in. You need to go and look at the record level data to look at the outcome of vaccination and what happened to it on a case-by-case basis. Now, here's the thing. All countries have this data. So what happened in Sweden was when they rolled out the vaccines, they also started a national vaccination register. And the idea of this really was to connect stuff to a vaccine passport. Within the EU, which they want to roll out actually by the end of 25, they started this back before the pandemic happened. This idea of setting up a register for everyone so their vaccines would be recorded electronically. So when you go on holiday, you could just, show it at the airport. Maybe you can't get on a plane if you haven't had this thing.
Papers, please.
Yeah, but the Swedish. So what happened with the rollout is the vaccines were free. Sorry, I won't call them vaccines. The jabs were free, but they also paid 30 euros per vaccine to the companies that did the jabbing or the health authorities, but only if they entered the name and identity of that person into the register. So they were paying 30 euros a shot to people to set this database up, and that's all coming from taxpayers' money. So because of that database, though, they know exactly when the majority of people had the shot, which batch they got, and that could easily be linked to the health records. It has been linked to the health records for the Swedish Public Health Authority and the medical regulator to look into this, to look into the safety of vaccines. And they've had that permission since, I think, 2021. They just extended it now out to 2027. So they don't have to actually report on the safety of the vaccines till 27. Why is that? I think it's just to hide it. But it just shows that, this data is available and it could be analyzed. Every country could do this, but they choose not to do it. Because they know, I think, they know what they're going to find. They know that people will be horrified. So it's just not coming out. So it's left to people like us to do this, in our spare time or on the back of other projects that as part of our day job, just to try and get some dialogue going about the situation and get people to talk about it. Because maybe we're wrong. Maybe this is just, it's wrong information.
Well, the difference is, Jonathan, if we're wrong or if you're wrong, we just look like fools. And we can live with that. Okay, we're idiots. We got a thing. No problem.
Yeah.
If they're wrong, we have a generation of girls and boys who could be, a lot of them could be infertile. So it's worth the risk of looking like a fool.
Yeah. And it's not just infertility also. It's, if the slide Kim showed about the rats taking up the RNA into the fetus and producing the protein in the fetus, those embryos will then, or fetus, and if that's a person, those babies will be born with a tolerance for that spike protein because their immune system saw it when they were in development. And now if they see it again when they're babies or adults or later in life, they're not going to have the same immune response to it than they would if they just saw it as part of a natural infection. So I think that might be why you see this in these 1 to 4 year olds. The last slide that Kim showed is why you start to see higher all-cause mortality in children that may have been vaccinated through their mothers, because their immune systems are just, they're not recognizing infections in the way that they should.
That's kind of the same with the general public too, and that's that's the IgG4. For people who are listening to this, if anybody's had allergy shots, the whole rationale behind that is that your immune system's constantly getting bombarded with the protein that you're exposed to on your cat or dog that causes the allergic reaction. So they're trying to make your immune system not react to that anymore. And that's technically what we all did, with the constant barrage, because none of us have ever required multiple vaccines. I mean, I have some patients now that probably had 8 of these things by now. Mm-hmm. When have you ever, even a flu shot is once a year, so it's the IgG4, which, it was either the Cleveland or the Mayo Clinic. One of the big clinics here showed their whole staff, the more shots they got, the more likely they were to get COVID infection. I see that in my own office. My staff is always sick. There's no such thing as a flu season anymore. Did you notice that? People are getting these respiratory viruses all year. It makes no sense. Well,
Kimberly. I talked to a teacher the other day, unvaccinated, who just got his job back in the last year. And he says that in his school where he's working, the teachers are always sick, the students are always sick, huge numbers. He said, but there's a lot of teachers who have false vaccine passports. So they're almost exposing themselves by not getting sick. So if you've got a falsie, you've got to almost pretend to be sick. You could be pulled in and going, hey, Jonathan, I've noticed you actually haven't been sick from 6 months ago.
You're too healthy, yeah.
It's bizarre. You're too healthy exposes you to the fact that you're unvaccinated.
Yeah.
Yeah, there's something I just realized while you were talking. If you're giving these shots, and the fetus is getting it, they're still developing their immune system. So they're learning self and non-self is how the immune system works. If they're exposed so early, they don't even need the IgG4 to have this effect of ignoring the spike protein.
No, their T cells will be trained that it's part of that part of the body, and that means if they see it, that they are higher risk of getting a much worse viral infection when they're older from something that has this spike-like protein on it.
Not only that, but probably the autoimmune, all the autoimmune things that people can get now. There's just going to be such a barrage of that in younger and younger people. It's just a shame. I wanted to also bring up, Michael, you had pointed out that slide with the blue, all the blue of the woman getting the injection and everybody's wearing blue. Well, in the right corner was a yellow sign, and there's all kind of, that's why the Ukraine flag is blue and yellow, by the way. There's all kinds of psychology with using those two colors and making people do stuff.
Really?
Yes, I read that somewhere a couple of years ago because everybody over here in the States, well, not everybody, you can tell who voted for which president when they have a blue and yellow sticker on the back of their car because they're all supporting Ukraine war.
Maybe that's why Swedes are so compliant, because we have the same colors.
I didn't even think of that. Sorry.
Well,
it's okay. It's okay.
There's a little symbol there of a blue bee called Be Free. And we've been looking for a symbol to identify ourselves, like-minded people, a symbol that people can wear. And we got approached by someone that said, have you heard of the blue-banded bee? It's an Australian bee. It doesn't live in a hive. It doesn't follow a queen. And it vibrates over flowers to lift the pollen out. So it raises the vibration of the flowers. And it also lives in a hole. So it's a rabbit hole. And so it's us. And so I'm just thinking, when you said blue, maybe we should make the bee-free yellow, and then suddenly we're using the same psychological technique.
Have it
No.
over a yellow flower.
We're using the Ukraine technique.
Oh God.
Oh my God.
Yeah. Yeah, I mean, just for me to round off, though, what I would say is, as from my scientific training, I've worked with kind of cell transfection with RNA, expressing various proteins in cells, in embryos, in different contexts, and this whole concept of using mRNA to try to vaccinate someone is totally flawed at every level of the strategy, I would say. And as Kim mentioned, you don't know the dose that someone's going to get. It doesn't stay in your shoulder muscle. It goes throughout your body. It targets the liver, the bone marrow, and the ovaries and testicles, more than anywhere else. It lasts in your body for ages. Most of it actually just stays in the cell and doesn't get, transported into the cell, but it interferes with the translation stuff. So there are so many aspects of this that everyone at my level should understand. But I go to seminars and listen to people that are trying to develop new RNA-based therapies, and they admit these things, but they still think it's a good idea. So the level of brainwashing in my profession is astonishing. I'm probably the only person at my university to speak out, and
It's amazing you're still there.
It is actually, but that's
In Australia, you wouldn't be.
Fortunate. But this is my job to speak out because it's my background, and I know this is harmful. But the issue is here. Basically, this was a way in to try to market other mRNA-based therapies. And if you want to start gene engineering people, if you want to put CRISPR-Cas9 into them to try and change genes, and there may be therapies for that which are needed, which are useful, but you need to get the regulation, the lower the threshold to be able to launch those therapies. And this is what they've done. They've used an infectious disease and a pandemic to try and roll this out, and now suddenly once this is out, it's much easier to license other therapies which are more complicated. So now they've in the Europe they've authorized this self-amplifying RNA vaccine for COVID-19. So this is an even more complex RNA. It contains viral proteins that amplify the RNA even more in your cells, even less likely to give a defined dose, even more likely to cause side effects. But they've just basically okayed it based on very little trial data in Cambodia, I think, Vietnam. And off the back of that, the drug company that developed it built a manufacturing plant in Vietnam for $200 million. So there's just the transparency of that deal where we do the trial and give you the data you want, and then we'll build you a plant there. It's just off the charts. It's like the Wild West.
But
the public don't know this.
Factory here in Melbourne.
Yeah,
can produce 100 million a year.
The Moderna.
No one's taking it. Yeah.
And one of my concerns, Jonathan, is that again we're calling it RNA injections, but I use synthetic RNA because this is not your natural RNA.
No.
This is methyl pseudouridine. It has very different properties which trick the immune system, which cause protein ribosomal frame shifting and misreading, and you get junk protein, and it evades the immune system, which is how Carrico and Weissman got their Nobel Prize.
Yeah.
So we call it RNA, but we should really be more specific. And the fact that it is non-natural is something that humans have never experienced. We might have a tiny fraction of this unusual RNAs, but it's very important, I think, that we call it out exactly for what it is.
You're right.
Cool. Like Moderna did. Modified RNA.
Yeah.
You okay, Michael?
It surprises me after 5 years that you can still be left stunned after all the things you hear, and they don't stop. They seem to have, it's quite incredible. Well, over here now in Australia, every single state has legalized full-term abortion, and if the baby's born alive it's left to die on a bench. They're not allowed to give it any pain medication, and that's legal now. So basically, that's moral. That's what I talk about. Two realities. They're forcing this other reality on top of us, where that's morally okay now. There's even a $4,500 payout for women who do late-term abortions. A loophole they've managed to get through. And there's just other things like this that you just, I don't know, you just feel like screaming. And yet all we can do is keep putting it out and putting it out. And I don't think there's anything else we can do at the moment. But it's fatiguing to know that, like here, we all are calling it out. And yet above us at some level, there's some sort of level where suddenly, no, it's great. It's I don't understand it. I don't understand how all these governments can push it. They can't all be getting paid. They can't all be complicit. They have to believe it like an ideology, and believe it so deeply that the evidence which shows that it's the emperor is naked just can't get through their skulls. What species in history of the planet would actually make a next generation, would risk the fertility of the next generation? Doesn't make sense. Cockroaches wouldn't do it. Rats wouldn't do it. I bet dinosaurs didn't do it. But for some reason it's socially okay to do that, and us calling it out, we're the crazy ones. It's fatiguing.
Everything's become inverted.
Yeah. I'd like to get you back on, Jonathan, because we do a lot of philosophical shows now. We're more interested in that, to what's happening, rather than the facts so much, because the facts seem to be bouncing off people's heads. But philosophically, I'm really interested in what's happening, because I think this is the time to define what it means to be human, where we're going, how'd we get here. These are profound questions we've got to ask, because AI is already coming in to say, hey, guys, we've got a nickname for you. We're calling you the Dodos. And so here we are. And I think this is a time to ask these profound questions.
I mean, that's actually what I'm grateful for. This has been tough, being awake, or whatever you want to call it, the last 4 years, but I'm very grateful, because it's made me consider what it is to be human, and what we can really contribute. And I think what you're doing, Michael, is wonderful. I mean, going around the country as well, talking to people, and learning from others. This is what God is.
You guys are doing data, but if you have another army people in the trench actually talking to people, the stories from the war and the stories from the data correlate. You know what I mean? So we back up each other's evidence. We've got a guy over here I interviewed. I think he's one of the most important interviews I've done. He's got 5 children, and 3 of them are on pacemakers now from different batches, and they all know it's vaccine related, different batches. So 2 sons and a daughter are now on pacemakers for the rest of their life. And I think that surely this one man and his 3 kids proves Big Pharma's data is crap, because it's statistically impossible for that to happen.
I mean,
so they'll say it's genetic, Michael. It's genetic. They all were genetically predisposed to heart problems. See.
I think one was half sister or something. So, but still, they'll still say
different mothers.
Well, this is part of the problem as well. I didn't show this, but we published another study looking at the batch dependency of side effects. So showing that in Sweden and Denmark, you had some batches that had a lot of serious side effects and some that had very few or relatively mild. So because the products have been different and how people's bodies deal with them is different, and some people have had this repeated exposure and others haven't, it's an extremely diffuse kind of side effects. So it's very hard to pin it down. It's not like thalidomide, you know, you see these babies born without any arms or legs, and it's very clear. This is much more malign in a way because you don't see it so clearly.
Yeah, we've got Sharon Cousins over here. She's put a whole thing of the batches. You can actually look up your batch here now on the website and find how it rates. You know, is it a Sith Lord batch or is it, you know, sound and
Yes,
music?
we're grateful for that paper. I call it the Schmeling paper, but I should be could call it the Guilthorpe. I could call it the Guilthorpe paper because your name is on there.
No, not at all. Well, there are two actually, Paul. So the first Schmeling paper was done in Denmark, and then I got hold of the Swedish data so we could actually replicate or look how if it was the same, and it was very similar between both countries. Some differences. So the second one was Manicha, Vibeke Manicha, but Max was on it as well. He's the statistician.
But it did show that there's something very weird about the batches, and it really raises questions about the standard of manufacturing practice, that you can have 4.2% of the batches having such, the lion's share of this. Just that alone should be enough. Forgetting about the fertility, forgetting about the cancer signal, forgetting about the excess mortality signal, forgetting about, and so on.
It's a signal, right? It shows you that the product wasn't manufactured to a standard, that every batch was the same. So now Anders Svid, who is a Danish Serum Institute, which is a kind of national authority in Denmark for both drug safety and vaccine manufacture and sales, he's just redone the Schmeling paper and claims there is no effect, because they've taken 1 million, 2 million cases and looked with great detail. But what they've done is use selection bias. So they've chosen a time frame to look where you wouldn't see anything. So they've gone, we don't see anything, but they haven't actually chosen the data that you need to choose to see something. They did this also recently with another study looking at aluminium in vaccines and whether it caused autism and other neurodevelopmental side effects. So you also have these people in positions of authority that should be analyzing things scientifically that are just on their own agenda.
Look at thalidomide. Thalidomide took 20 years, didn't it?
Yeah.
From when the signals first came up before it was banned.
Yeah.
I mean, it's 20 years of them holding on to profit.
Yeah.
Over the children.
And then they rebranded it and started selling it in Spain again. So
You're kidding me.
Yeah, no, that happened. They were still marketing it in Spain under a different name. So big pharma are evil. They don't care who they injure. They just care whether they can get away with it. And
but if they injure you, you're applying for life.
But for vaccines or things called vaccines, they have this indemnity, so they don't carry the can.
Yeah, they've got a perfect business model. Perfect business model. Yeah. You can't sue them, and if you're injured, who do you go to for the remedy? To them. Yeah. So it's a perfect business model. You add a load of greed in there, and shareholders begging for dividends, and suddenly.
You just need to capture the regulators and massively fund the propaganda and censorship business to keep your message out there.
And we saw that if you watch that film, The Big Short. In The Big Short, it shows that the regulators or all those knew also that the housing crisis was a real concern, and they ignored it, and they kept giving approval ratings and stuff like this. So you can see that the corruption is at this level now. This is the capable of it,
Yeah.
We've actually got a thing over here. Sorry to keep you guys, but if you ever meet someone that says, how can you possibly believe that everyone could lie to you? And we're saying now, well, yeah, easy, Santa Claus.
Yeah, exactly.
When you were 5 years old, you believe Santa Claus. You might have one clever kid in the kindergarten who goes, doesn't exist. You go, hey, you conspiracy theory. What are you talking about? I got someone eats my cookies, not got presents under my tree, you dumb idiot. But at some point, you wake up and you realize everyone you loved, all the media, all the politicians, absolutely everyone in the world has been lying to you from the womb to about 7, but you survive.
Yeah.
And this is where we are.
Yeah. I've reflected on that before as well. It's a good one.
Yeah. Any more horror stories, or can we go? I'm just about to go have a huge joint and try to vanish from the world for the rest of the year.
No, I have a good thing.
Good, go.
I think Roz has convinced me to come to Australia.
Oh yes, Perth.
For the retreat or whatever you're calling it in January.
Byron Bay.
Yes. So I bought my Australia book and my map, and I'm gonna see if we can make it happen.
Oh my God, let's hope that the government doesn't see this show or they'll ban you.
Oh, well, that's a question. Do I have to be jabbed to come there?
No, just compliant.
Well, that might be a problem.
Let's come dressed in blue and orange. They'll never blue and yellow. They won't notice.
Yellow. I don't look good in yellow.
You see the colours behind me now, don't
you? Yeah, man. I'll tell you, I made it from yellow to the beach. That's it. That's yeah, it must be trusted colours. But it's anyway. Here we
it's heavy stuff, Michael, but it's very important to
I've been in this for 5 years. It is heavy. We had a woman over here, young mum, unvaccinated, and they take the kids. We helped get them back, but they take the children, see them as irresponsible parents. This is crazy shit. It really is crazy, And New Zealand, look at New Zealand with Brian, was it Jones? Paul? Who was the one that brought all the...
Barry Jones,
yeah, Barry
and he had record level data, because he was a database administrator of for the payment of the shots. And he merged that with the so you could see the date and the time, and you could see all these anomalies just without people who came in to the same clinic on a Saturday morning, and a lot of them weren't alive. It was just mind-boggling. Again, about batches. That was one of the things that stood out. We need more record-level data. It needs to be made de-identified, so it's not a privacy issue. It's a health and safety issue, and we continue to demand it. And I don't think we're going to shut up until we get it.
No.
But he's going to jail, probably about 7 years. So
I hope
not. But he's fighting for his freedom now. Yeah, amazing. Thank you, Dr. Biss. It's a joy to have you on all the time. This is the second time now. Even though you're bringing sort of a really crap message, it's still lovely to have you on. And Jonathan, it's been a delight to meet you, Jonathan.
Yeah, thank you.
Now, I'm 59. I actually Welsh born. And what I remember in Wales when I was 5, and it might have been the same for you, was when they were vaccinating us, I think it was smallpox or something, all the kids were in their undies. And we were just all lined up. I can remember that. And you were just a big line of us. They just grabbed you, boom, 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 gone, jab, boom, gone. So it's interesting. I can't remember being asked anything. I don't know if my parents were asked, but it's a strange world we live in, isn't it? Where we somehow think that the universe or the gods have sent us this child, but it's incomplete unless we fill their veins full of shit.
Let's make t-shirts.
It's true.
You're incomplete.
Yeah.
If you don't laugh, you'll cry. People are probably like, why is she laughing? But
Oh yeah, we do that a lot, especially with the Eust. I think it's the only way we cope. Yeah. But thank you for coming on. Be in touch. This will go up tomorrow night, our time, about 8 o'clock.
All right.
I have no idea what time that is for you guys, but we'll get it up and we'll send you the links through. Thank you so much. And
Lovely.
thank you for the work you're doing. Seriously,
Thanks,
thank you
everyone.
for the work you're doing.
Yeah.
And I wish you the best.
Likewise.
Take care.
Thanks, everyone.
Jonathan.
Bye.
See you. Bye now.